If you're a medical trainee, you already know that some of our most important, most meaningful work happens in a patient's final days. So in this explainer, we're going to walk through the clinical guidance on how to provide care that is both compassionate and effective right when it matters most.
Okay, let's dive right in. The second we recognize a patient is entering their final days, our entire clinical focus just pivots. And this is such a profound shift, right? We're moving away from treating a disease and moving entirely towards ensuring a person's dignity, their peace, and their comfort.
So first things first, our primary job as clinicians is to accurately recognize when a patient is entering this terminal phase. And getting this right is absolutely crucial because it lets everyone, the clinical team, the patient, and especially their family, set realistic expectations and plan for what's to come.
So what are we actually looking for? Well, clinically, there are a few key signs. You'll see a patient become bedbound, they might have changes in consciousness, and they'll show this sort of natural indifference to food and fluids. It's so important to understand these aren't failures of care, they're markers of the body's natural dying process.
And we can get even more specific than that. There are certain signs that strongly, and I mean strongly, suggest that death is likely within just a few days. You want to look for altered breathing patterns, like those periods of apnea, and some really distinct physical changes, like the drooping of the nasolabial folds.
Recognizing this transition, that's step one. Step two, which is just as important, is communication. This is where your role really evolves, and you have to make sure that every single medical action from here on out aligns perfectly with the patient's final wishes. This right here, this is the single most important question you can ask. And, the research is pretty clear on this. For most people, it boils down to two main things: excellent symptom management so they don't suffer, and a really clear, shared decision-making process.
You have to have a proactive conversation about CPR. It's essential. For a patient who is actively dying, it is so crucial to explain that CPR is just not a beneficial intervention anymore. In fact, it can be physically traumatic, and it could actually prevent the peaceful death that we're all trying to facilitate. And look, this conversation has to include implantable devices. Just think about it. An ICD delivering a shock to a dying patient is the absolute opposite of comfort care. Deactivating these devices is an appropriate and honestly necessary step to align with a palliative approach.
Honoring a patient's preferred place of death is a key measure of quality care. Don't ever assume you have to ask the question. Overwhelmingly, when you look at the surveys, most people say they would prefer to die at home.
And the choice of location makes a real difference. Dying at home is consistently linked with higher family satisfaction and what studies call a better quality of death. Now, of course, the hospital or ICU can provide vital support, but that environment can be really challenging. So our goal, no matter where the patient is, has to be creating a space of privacy and peace.
All right, let's switch gears and get into the science of comfort. This section is all about the practical, evidence-based symptom management that can make just a profound difference in a patient's final days.
The very first principle is deprescribing. We need to stop all non-essential medications. I'm talking especially about preventative ones like statins or certain antihypertensives. Honestly, every single pill we can take away is one less burden for the patient.
Now for pain, opioids are the standard of care. And this approach is key. You start with a short-acting opioid and you titrate to effect. But here's the crucial part. Write the order as offer, may refuse. This makes sure the patient gets consistent relief without having to be awake or lucid enough to actually ask for it. It's a game changer.
For that feeling of breathlessness or dyspnea, something as simple as a bedside fan can be remarkably effective. Low-dose opioids also really help. But notice, supplemental oxygen is only recommended if the patient is actually hypoxemic. Otherwise, it doesn't really help the sensation and it can just be burdensome.
When you're dealing with terminal delirium, you always start by looking for reversible causes, like a medication side effect. A lot of the time, a calm environment and just some gentle redirection are all you need. Pharmacologic treatments, like haloperidol, are really reserved for cases with significant agitation or distress.
That rattling sound, you might hear it called the death rattle. It comes from a buildup of normal secretions that the patient is just too weak to clear. And let me tell you, it can be incredibly distressing for families. The most effective first step is simply repositioning the patient. Medications to dry up secretions are really a secondary option.
So, our clinical care doesn't stop with the patient, not even close. One of our most vital roles goes way beyond medication orders.
It's about preparing and supporting the family through what is just a profound and incredibly difficult experience.
This quote from the clinical guidance really gets to the heart of it all. Preparation is key. Your single most powerful tool to reduce a family's distress is education. Simply explaining what's about to happen and that it's all a normal process can prevent so much fear and panic at the bedside.
And you need to be really explicit about it. Tell them their loved one will likely stop eating and drinking, and that this is okay, that artificial nutrition won't help. Explain that their breathing patterns are going to become irregular. Prepare them for the sounds and the other physical changes. This knowledge is truly a gift.
And it's also so important to empower the family. Remind them that even if their loved one seems unconscious, hearing is often one of the last senses to fade. Encourage them to talk, to touch, to just be present. The sound of a familiar voice can be profoundly calming. Their presence really, truly matters.
Okay, finally, let's just quickly walk through the necessary steps in the moments immediately after a patient has died. Handling this part with professionalism and compassion is really our final act of care.
The protocol itself is pretty straightforward. First, a clinician has to pronounce death. Then the family is notified. And here is a critical point for home hospice. Instruct the family to call the hospice nurse, not 911. This avoids a totally unnecessary and chaotic emergency response. And finally, of course, the death certificate has to be completed accurately.
So, after all the protocols and the pharmacology, what's the most important takeaway here? It's this. The clinical knowledge is absolutely essential. But what will truly define your excellence in end-of-life care is your ability to blend that science with a compassionate human presence. And that right there is the art of medicine.